Today, we're going to be talking about ovarian carcinoma, specifically reviewing a case of a patient diagnosed with recurrent advanced stage high-grade serous ovarian cancer. This patient is a 71-year-old female who presented to her primary care physician for a follow-up visit where she was reporting progressive fatigue as well as abdominal pain. Importantly, the patient had a history of ovarian cancer initially diagnosed in 2017. Based on her initial disease distribution, she was presumed to have stage 4A disease and was treated with a primary surgical cytoreduction, although unfortunately she had a suboptimal resection with residual tumor greater than 1 centimeter in the abdominal peritoneal cavity. In the context of her initial disease stage and after her surgical intervention, she was counseled and treated with adjuvant chemotherapy using carboplatin, paclitaxel, and the anti-angiogenic agent bevacizumab. She received 6 cycles of the triplet combination regimen and was subsequently treated with bevacizumab maintenance therapy. Thankfully, on bevacizumab maintenance therapy, she achieved a complete response and was subsequently in remission. Now, the patient presented to her primary care physician as outlined above with these nonspecific symptoms. And these nonspecific symptoms presented 2 years after her initial surgical resection and after completion of her frontline therapy. Unfortunately, CA-125, which was drawn at that point in time, was elevated at 456. And in parallel, radiographic imaging in the form of a CT scan of the chest, abdomen, and pelvis was obtained, which showed suspicious lung lesions that were suggestive of disease recurrence. And these were subsequently biopsied, helping confirm the fact that this patient had recurrent high-grade serous ovarian carcinoma to the lung. Tissue was subsequently submitted for molecular characterization, specifically assessing homologous recombination deficiency and LOH status, as well as potentially other genomic aberrations. And this patient's tumor was found to be homologous recombination deficient based on loss of heterozygosity assessment. The patient did previously have germline testing and was BRCA wild type without a known genetic inherited aberration or mutation, and no other actionable alterations were noted. In follow-up, after the patient was diagnosed with this disease recurrence based both on imaging and biopsy, she was counseled regarding therapy. She had platinum-sensitive disease recurrence given her prior disease-free interval, and the decision was made to proceed with a combination platinum-based regimen with carboplatin and pegylated liposomal doxorubicin. She received 4 cycles of systemic cytotoxic chemotherapy, had a response to treatment, with a reduction and resolution of her CA-125 to normal levels, as well as radiographic imaging showing no definitive evidence of residual or metastatic disease. Importantly, after 4 cycles of carboplatin and pegylated liposomal doxorubicin, the patient was counseled about the opportunity for maintenance therapy in this platinum-sensitive recurrent setting, and she did choose to proceed with treatment with maintenance single-agent rucaparib at 600 milligrams orally twice daily. And she remains on that regimen currently, again, without evidence of disease recurrence.